Good afternoon, ladies and gentlemen. I'm Dr. du Plooy. I'm standing in for Professor Mohammed Tikli from South Africa, who, due to unfortunate circumstances, can't be here. And I would like to thank the organizers for the invitation to him. I work in training hospital in Johannesburg, in Soweto, and that's what I'm going to talk about. The current practices in the management and monitoring of moderately active and life-threatening lupus in South Africa. Sorry, which one? Okay. And this was sort of data put together by Professor Mohammed Tikli from Wits University, Professor Aska Kalla from Cape Town University, and Professor Girish Modi from Durban University. The setting in South Africa, the region it's a middle-income country with a total population of about 48.5 million people. The catchment population in this data is about 10 million for the 3 tertiary hospitals, which is located in Soweto, in Johannesburg, Durban, and Cape Town. The number of lupus patients actively being followed up at these 3 hospitals are about 600 per annum, and the number of newly diagnosed lupus patients per annum is about 80, and it's more or less 20 per hospital. And the same with the 600 patients, fairly equally divided in about 200 per hospital. Healthcare financing in South Africa is mostly state-funded, which is about 83% of the population. The rest is private medical insurance. And the health expenditure in South Africa is about $200 per capita, although the latest figures by Department of Health have indicated that it's gone up to about $400 per capita, versus the $1,500 per capita in the private sector. So you can see the inequality in that. The number of rheumatologists for this catchment area, these 3 hospitals, are about 11, and our hospital has got about 6 consultants. The country as a whole has got about 55. The drugs available for treating lupus at these hospitals are chloroquine, corticosteroids, methotrexate, cyclophosphamide, azathioprine, and then we've got limited access to intravenous immunoglobulins as well as MMF, CellCept. The protocol for moderately active lupus in our setting is we do a follow-up. Our follow-up frequency is about 2 to 3 monthly. And the laboratory tests that we do and have fairly good access to at baseline is a full blood count, ESR, CRP, the complements C3 and 4, ANA, anti-double-stranded DNA, ENA, anticardiolipin antibodies, lupus anticoagulant, urine dipsticks, and microscopy, and then we do HIV on all our patients. I think we've got a little bit more access to more investigations than you have in Barbados. Then the follow-up tests, and these are done on a 3-monthly basis, is full blood count, ESR, CRP as well, complement C3 and 4, anti-double-stranded DNA, and urine dipsticks. And the frequency of the tests is at each visit. What is the protocol for treatment for life-threatening lupus? Initial treatment is IV methylprednisolone, 1 gram, 3 to 5 days, usually about 3 days. And this is followed up by IV cyclophosphamide. And depending on what the indication is, if it's lupus nephritis, then we give it monthly for 6 months, or if it's hematological indication or neuropsychiatric indication. The question about when do we start tapering the medication is really clinical if the clinical signs of decreasing activity shows, or if there's maximum of 5 days of IV steroids. Although it's more likely to be 3 days, I must say. Then the outcome, Prof. Leung has mentioned that this morning in the one paper which was done by Wadi et al. On our outcomes, about the 5-year survival, which is 72%. But this is the best case scenario. In this study of Wadi et al., they took the patients, there was about 40 patients in the cohort which could not be accounted for. They were lost for follow-up. And the question, if those patients are put with the patients who were not where they were not added to the deaths, then the outcome would be 72%. But if they added to the patients who were dead, then it's the classification of that, then it would be about 55%. So what are the most important needs to optimize outcomes for patients with lupus in our setting? Again, early referral and shared care with primary healthcare services are extremely important. And it's education of patients, of healthcare workers, of physicians, and then also training of rheumatologists. And then we've got quite a high number of chase-up defaulters, and we have to chase them up. And really to identify the reasons why they default. Often it's lack of money, and they don't have transport to the hospital. If they do not have disability grants, which we usually apply for them, then they have to pay at the hospital with each visit. And that really improves their non-compliance if they don't have a disability grant. Then we need to identify the patients at risk for severe infections and TB. And in the study done by Wadi et al. As well as Hodgkinson et al., it's been indicated that the poor prognostic features for lupus or for risk factors for infection, for survival in our lupus patients and for infection is really the black ethnicity, the black population, and then if they've got low lymphocyte count, if there's hypocomplementemia, and then the duration of the treatment, of corticosteroid treatment, and whether intravenous corticosteroid treatment was used, as well as the immunosuppressive drugs. Then if we could have proper ICU support for the severely ill SLE patients, which we don't have, it's mostly anesthetist-driven, so they focus more on trauma patients, and it's known in our ICU that lupus patients don't survive well, so they don't take them due to poor prognosis. Renal replacement therapy and transplantation, we have moderate access to that, but due to resources, it's limited. So, and then the availability of biologics, for example, rituximab for refractory disease, that could be of great assistance. Unfortunately, it's not available in the public sector. And with that, I thank you very much for your attention.